services.
Audio is live. All right. Your audio is live.
Good morning, all. I am going to introduce our speaker today. His name is Mikhail Schneider. He is the founder and chief executive officer of Nightingale Education Group. He is a mission-driven organization focused on innovative healthcare workforce development across entire professional continua, from certificate programs to graduate studies to reskilling and upskilling through continuing education. From 2012 until 2023, Schneider served as the first president of Nightingale College, a higher learning institution dedicated to closing education equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession throughout the United States. A registered nurse for more than 25 years, Schneider has a wealth of management experience in post-secondary education for health professions and healthcare delivery systems. He is a published academic author, conference speaker, a guest lecturer, specializing in strategic planning, organizational development, forecasting, and management. Schneider holds a Master of Business Administration degree from the University of California at Berkeley's Haas School of Business.
Thank you, Brienne. All right. And Brienne does a lot of things at the organization, organizing these type of events. Well, welcome everybody again. Those of you in the cyberspace, hello. Hopefully you made it on time. These folks did, and they had to, go through the rain and whatever else is here in Alaska. We're coming to you from Alaska today, from Anchorage. A few things. Obviously, everybody's here for the Future of Nursing workshop. Yay, fantastic. All of you out there as well, hopefully. Okay, so a couple of kind of ground rules for today. A is that those of you in the cyberspace, there's chat galore. You can participate. Sometimes we're monitoring it, and sometimes I'm going to call on Brienne to tell me some good things that are appearing in the chat. But we mostly will be chatting here in the physical space. I love 3D. 3D is my new favorite thing. Everybody after COVID, right? Like 3D feels really, really good. Okay. So that's number one. Please participate wherever you are. Number two, when you think about everything that we will talk through today, when you think about it, make sure that you are thinking for you. So this is what I mean. Some of you watch that Fox News thing, some of you watch MSNBC or whatever else, right? So the pundits on TV that go yap, 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 and yap, 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 and da-da-da, and there's a lot of opinion out there on the things that we will be talking about. What I'm asking you to do is remove the pundit hats, right? Leave that behind for today, and hopefully the rest of your nursing career, and rather put on a hat of a nurse. And the nursing as the profession, and bring into it, nursing, you probably have learned already, is an evidence-based profession. What does that mean? Evidence-based, yes?
Through research and through doing.
Yeah, so we learn things. We base whatever we say, whatever we do, in whichever way we deliver care, we behave, we look at things. We look through the prism of evidence that comes through research, that comes from practice, that comes from experience, and all of that. Not everything online is evidence. Everybody gets that? Okay, great, because some of it AI made up, right? You put a few things in ChatGPT, prompted to give you some, crazy things, and it will happily produce it, and it'll sound like a real thing. Not evidence. Where do we find evidence? Yes? Peer-reviewed journals, right, publications, that's a good place for evidence. Where else do we find evidence? Yes?
.govs.
Right, so there is organizations like governmental organizations and so on that actually publish a lot of it, right? Especially in population health and things like that. You can find it in those places. CMS, right? Centers for Medicare and Medicaid Services, Department of Health, counties, all sorts of governmental organizations that publish that. And there are also a bunch of nonprofit foundations, kind of organizations that do research in the name of the public good and don't have any particular political affiliation. They're just, don't have an ideological slant. They just produce research and evidence to help us navigate this complicated world. So we're going to hopefully be relying on evidence today to see how we're doing, right? And then the cool part of it is that you all and you out there get to sort of imagine, right? Brainstorm and think about what it is that you can do as an individual practitioner and in groups of nurses when we band together to change the state of affairs that we have today on our hands. So sounds good? All right. Yes, for those of you in the physical space and those of you in cyberspace, I know bladder sometimes is like, you can't, it calls. So if you have to get up and go away for like a couple of minutes, come right back, right? Other than that, though, at about an hour and 10 or so in this presentation, an hour and 5 minutes, an hour and 10, we're going to pause for a break, and then everybody can go. So on Alaskan time, that's going to happen right around 10:15. Yeah, everybody good? Because right now it's 9:15. All right, everybody ready? Awesome. Ready to go? Oops. What happened? I turned it off. No, I didn't. Okay, yay! There you go. The slides are in. So yeah, that's me. That's what we're talking about. I mean, that's not me. The name, like over there, me is here. Okay, so let's start with this. Before we go into anything else, anybody has perused at all, like an executive summary perhaps, of the Future of Nursing report that came out a couple of years ago now, or was it last year? No, 2021. 2020-2030 Future of Nursing report from the National Academies of Medicine. Anybody? No? Okay, yeah, don't be shy, like be very proud of it. Yes, I looked at more evidence than anybody else. Fantastic. And those of you who haven't, make sure you go. It's National Academies of Medicine website, and you find that report. You can Google report, and it'll populate. You can download it in PDF for free. It's there. It has a lot of information from many different constituencies and recommendations for constituencies as to how to change this future, this unsustainable path, essentially, that we're on in healthcare. And so what the Future of Nursing Report 2020-2030 calls out as kind of front and center is health equity. And it says we must improve health equity in the country. So let's start digging into what that means. Let's take the word equity first. What is equity? Come on, there must be ideas. Yes, please.
Being equal.
The what?
Being equal.
Being equal, not quite. Being equal in something or similar in something, but it's not quite being equal. Yes?
Having worth.
Equity recognizes that every human being has an inherent worth, right, and is worthy of equitable, treatment, equitable outcomes. So what is equity? When equity truly exists, what does it mean? Yes?
Being fair and impartial.
So there is fair and impartial, fairness and partiality is a part of it and exists there, but what's at the heart of it? Why we say we want to achieve health equity? What does it mean, health equity? Yes?
To not look at the person as a whole and treat them for what they're there for.
look at the person as a whole, treat him for, you know, like we're kind of dancing around the actual definition. Yes?
I think what you're talking about is just like equity, like there's like a gap between different populations.
Correct. Absolutely. There is a gap in outcomes between different populations. US population. Everybody kind of grasps that simple math. So one nurse for every like 100 people, less than 100 people, right? On Facebook you have more friends than that, right? It's more than 100. So yeah, you're it. If nobody else is a nurse, and there's a couple of nurses, then you need 200 friends, right? That you are taking care of. But truly, if we figured out collectively how to unleash the power that we actually hold as nurses, the entire system would change. By the way, I'm going to quote Deming. And yeah.
We're having virtual issues.
Oh.
Can we pause for just a second?
Sure. Virtual issues. We're going to pause for just a second, process it, stretch. Yeah, maybe. Yeah, we're good. Okay, and we're back with the technical difficulties. Yay, you know, I've been told about Alaska Broadband, and that's why we're trying to figure out how to do it on the satellites, right? Hopefully those Oculuses will connect to a satellite at a certain point, right? And not to broadband, but you know, we're not there yet. Okay, so anyway, imagine a world where 4 million or more than 4 million, and we need more, right? We know the shortage really exists. And so if, you know, all of these nurses actually moved in the same direction of making it personal business to drive health equity into the populations that each one of us serves, right? Imagine, and I truly believe it is possible, and I think that you all here, out there in the cyberspace, you all will do it. And this is why we're holding this workshop really early in your nursing education. And soon I'll get to all of them nursing schools throughout the United States to convey this same message. It is possible. So the Future of Nursing report says this. I know it's small, so I'll read it to you. We will never thrive as a country unless we all have what we need to live a healthy life, no matter who we are or where we live. We've determined that, yeah? It's like everybody needs health and wellness. 2, nurses are catalysts for this change. They're trusted bridge builders who collaborate with people, communities, and organizations to promote good health and well-being no matter one's background. Yeah? So if you sit here and your questions like, you know, I like to work only with some people, because those are the worthy people, and then the rest of you all, sorry, oh, profession not for you, just like stop now, go into architecture. And I was going to quote Deming, right? This is like, I'm coming back to it. In the 1950s, he said, I'm like, it's a loose quote, but the gist of it is this. Every system is perfectly designed to produce the outcome that it is actually producing. Everybody with me? every system is perfectly designed to produce the outcome that it is actually producing. So what does it mean? I don't know. Maybe we can do some kind of setting on there that it doesn't go to sleep. Because I'm not going to move it any faster than that. Anyway, so which means the outcomes that we're getting, that we're going to be discussing today, are by design. It is baked in. Our system is designed to produce those outcomes, or the lack thereof. Everybody with me? And in order to, so Deming's point was this: in order to change the outcome, you must change the system that leads to it. Everybody good? So there's no question that change must come, and that's what that second thing, actually number 3, talks about. For our country to advance health equity for all, the systems that educate, pay, employ, and enable nurses need to permanently remove practice barriers, value their contributions, prepare them to understand and tackle the social factors that affect health, and diversify the workforce. Yeah? Why is that last one important? Diversifying the workforce. Why is it important?
Because it includes everybody.
Correct. Well, and just a fact. Nearly 80% of the U.S. RN workforce is white. In about 75 are white female. Yeah? That's our population. And look, white folk, yay, I'm with you. We still need you. It's just we need everybody else as well, right, in this profession. Because time after time after time, the literature is conclusive on the fact that when the care is provided by the workforce, which is closely reflecting demographically and socioeconomic background of the population that they serve, the outcomes are better, the care is more effective, and it's more efficient, and it's actually cheaper. Right? And you all can think about sort of folks like you, right? Just, if you're a white male, think about it, right? You probably get those folks better than, and especially in the geography that you live in, right, than anybody else, right? The prevalence here's the least represented in the nursing profession are black males. Now, I'll give you a different statistic, that black males die from a preventable cancer, which is a colon cancer, more than anybody else in this country, in bigger proportions than any other population. Do you think that outcome has anything to do with the fact that they're not represented in nursing? I would dare to say yes. It is very difficult, and there's cultural and kind of historical and all sorts of dynamics that go into that if the practitioners closer reflected that population that they served, you will see that rate going down, prevention going up, right? Yes?
I hear a lot from my patients that they don't pursue nursing or medical because of cost.
Yeah.
I hear so much.
Yeah, cost is an issue, and we'll dig into it. I'm just getting to addressing this slide, which is really, really important for you to understand. And so, again, everything must change about the system in order for it to produce better outcomes. So we're going to, for those of you in cyberspace, we are going to put a question into the chat, and you all answer the question, and that question is, why is health important? This is all for you. I'm going to give you a few seconds to think about it, and then we'll have a conversation about that. And those of you in cyberspace, why is health important? That question is going in to the chat. And by the way, if you signed in to the chat with like, you know, kitty cat number 2 or whatever else, we will not know it's you, and you will not get credit for your attendance. So hopefully you're signing in with your name, and then we can monitor that engagement of yours with that. Meanwhile, I'm sure there is a setting on this computer that fix it. You can fix it now while we're talking about it. That, you know, this laptop loves saving electricity. That's what, like, its goal in life to save electricity. All right. So why is health important? Why we're all like in such pursuit of health? Why is it important? Yes. Quality of life, right? So the more well somebody is, the better quality of their life that they experience, right? And wellness isn't necessarily just physical wellness. Everybody understands that. Wellness actually, you know, and again, and this is from some research and some studies, they suggest that there is 8 dimensions to a healthy living, healthy human being, right? Physical definitely is one of them. What else, you think? Yes. Mental, yes. Environmental, yes. Other things? Yes. Emotional, yes. Mental and emotional, 2 different things. Yeah? Yes. Spiritual wellness, yes. What else? Come on, we're almost there. What else do you need to kind of have a high quality of life? Yes. Yeah, so that kind of goes into physical wellness, the nutritional. Yes, please. Financial, yes, right? It's like, you're not in great shape if your finances are in great shape, if you cannot find enough money to live, right? And to provide that nutrition that is needed, and so forth. Yes, please.
Your social life.
Social, absolutely. We constantly forget that social wellness is a thing, and it's real, and it's not achieved through any social media. That is like the opposite of social wellness, of what's happening on social media. Yeah? It's like consumerism wellness, perhaps, but not, you know, not real social connection, not real. So that's why 3D is still very important for you folks. Getting together, holding hands, singing Kumbaya, whatever you do, you know. Really, really good, really important, really important. Okay, so, and one more that we haven't mentioned is occupational. Right, occupational wellness, being both safe in whatever it is you do, right, in whatever profession you have chosen, whatever work you're doing. How safe are nurses right now? Yeah, how safe is the nursing workforce? Not that safe, no. There's not, occupational wellness doesn't exist, right, because of the shortage, and that's just one factor that contributes to it. Because we're constantly told as nurses that patient first, you second. That is not going to work long term. It hasn't worked, really. Self-care first, you first. Then the patient. The systems is not set up. The employment systems are not set up. That's why it's calling it out over there. Are not set up to ensure that nurses actually can achieve wellness first themselves, right? So they can drive it forward. So you will learn a lot in your program around that, the wellness and sort of, you know, and I invite you to apply it to yourselves, right? And kind of evaluate where I am and then what do I need in order to become more well in something. Obviously, all of you are pursuing financial wellness. Yay, that's awesome. But consider other things. Ask yourself, how am I doing socially? So on and so forth. So that is important. Quality of life. That is quality of life. What else? Somebody back there. Why else health is important? Why would I care about your health? The future, yeah, that's sort of a good kind of like the future is why we care. Because healthier people who have higher quality of life, then, if that happens, communities start flourishing, right? Thriving, producing, yay. So the economy becomes better, right? So that there are some facts. Population health is directly correlated with societal economic prosperity. The healthier a nation is, the more economically it is more well. And if on average everybody is better off, you can almost draw that parallel that individuals then are better off, right? But we're turning it around and saying individuals have to be better off first, achieve those health wellness outcomes that anybody else, and then from that you see then the economic output, right? The healthier workforce is the happier workforce. If you're healthy, guess what? You get up and you're like, yay, work! Rather than, oh. That's not occupational wellness, by the way. If you're like, oh my word, I have to do that again. So, anyway, anything else? Anything else? So it's important. It's important for individuals. It's important for families. It's important for communities. It is important for everybody. Yeah? And how are we doing in the United States? Yeah, not well, comparatively, right? Because look, if you compare us to some, countries in East Africa, oh, we're great, winning. Not the right comparison, though, right? Because those countries did not spend many, many dollars, and we'll talk about how many, as we did, on trying to have a better outcome. So as a matter of fact, comparative performance, this is from the the Commonwealth Fund, a nonpartisan research organization, nonprofit, that compares healthcare systems, compares healthcare outcomes. They do it in, throughout the world, and they do it kind of county level in the United States, state level, so forth. If you go on the Commonwealth Fund, you can find a lot of information. And if you want to dig in of how Alaska is doing, compared to other states, you can easily find it there, and you can see where you are. I have a couple of stats on Alaska for later, but yeah. So and this is our proper comparison group, developed Western nations. Yeah, we're industrialized, we're all of that. It's like da 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 da, and then boom. Like a period on a downfall. So yeah, comparatively, we are the lowest performing system with the lowest outcomes in the developed world. Yet we spend the most. So that's interesting. Okay, let's look at this next one. This is how much we spend. That top line, that's us. Those other lines, those are the other countries. So we spend the most. Everybody sees that. We get the least for it. That's by design, people. Because what we're spending and how we're spending and where we're looking and what we're doing and how we're educating and all of that is not. That's what leads us to this. So and this is the 2019 comparative data. The last data that was available is 2019. Obviously, the COVID threw a wrench into all of this, and I'd be interested to see when a new study comes out, which should come out probably this year or the next. So you're like,
2021 they came out.
oh,
17.8%.
yeah, 17.8. So we're climbing, and that is percentage of the gross domestic product, which means our entire economy, that is the gross domestic product. All the milk that is sold, all, you know, the education that is provided, like all of the services, all of the cars, everything, every single dollar that was spent in this economy, this is in a year, we are approaching 20%, 1/5 of our economy is health care. Or shall I say sick care, really? Because, you know, we're not doing that well on the health part of things. Yes?
When I was doing my scavenger hunt
Yeah.
assignment, I saw a quote that said, we have a health insurance system and not a health care system.
Right. It's a health insurance system, which is, you know, and we'll talk about that a little later, of how fractured and disconnected it is. Those are all the factors that go into, and all I'm doing with these few slides and like really showing where we are. We're going to dig into, as we go, we're going to dig in deeper into why that is, right, and what's contributing to it. Yes, you had something. Okay, all right. So this is per person that lives here in the country. Yeah, everybody's like, dee, 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 and then boop. That's what we spend. So we spend a lot of money. Now, this is per, like, actually capita. The people that have been counted in the census, right? Are all those people who have been counted in the census actually had access to care and are counted in this spend? No. So this is just what we spend. Not everybody had access. And we spend this, and then we divided it by everybody, we get to this number. So the real spend on somebody who has access is actually even higher. Yeah. Compared to spending, everybody's in cluster. Boop. That's us. I know. You see the trend, huh? Affordability. Yes.
On your last slide,
Yeah.
actually just wanted to say there was a 2021 data that came out, and it's actually up to 12,900.
12, right. And again, this is, I'm going to show you the new data from CMS a little later. This is the Commonwealth Fund, because CMS doesn't necessarily compare it, right? And we don't have the comparative scores from other countries. So this is why I'm showing 2019 as a comparison, because that's the last comparison that's available. And again, it might change with COVID, but we know from kind of COVID research that, again, we did worse than anybody else, really. And so, whoop-de-doo, winning. Again, comparatively, affordability, comparatively, equity, comparatively, cost-related due to income, right? So what this shows is that the lower income you have, the less access you have, the more problems you will have, and all of this. Nobody's surprised by this, right? It's like, it's just, but the data is there. And so yeah, so it's percent who report any cost-related problems to medical care in 2020. And so 50% of those with lower incomes have access-related, cost-related problems with access. Even people with higher incomes, 27%. Avoidable deaths. Everybody's reducing theirs by, like, double digits. We're like eked out 5% reduction. Yes?
I feel sometimes like we are so crazy about trying to prevent that we use unnecessary measures trying to prevent, which cause extra issues. Do you think that?
Well, prevention, actually, there's not enough of it, and we'll dig into the prevention itself. Prevention is much cheaper than preventing something from happening. Costs way less than it happens, and then you end up in acute care, for example, which is very, very expensive, right? So preventing that from happening is actually a better investment of the dollars rather than letting it go and letting it go and letting it go, obviously not spending, not spending, not spending, and then paying way more than we otherwise would if we have prevented it. So, and again, we'll dig into that a little later. So mortality, preventable, life expectancy at birth. Our curve is going down. It actually has worsened since 2019. Thank you, COVID. Yeah, it's like whoosh. Compared to others. Winning. Speaking of social wellness and mental wellness and emotional wellness and occupational wellness and financial wellness and all of that wellness. I'll give you actually on that previous one a statistic. Let's see. Well, I'll save it. I'll save it for a little later. Okay, suicides, multiple chronic conditions. This is more, 2 or more chronic conditions, 1/3 of the population. 45% of the population, close to half, has at least one chronic condition. Winning, that number is even higher now. 42% of US population is considered clinically obese. That's BMI of 30 or more. So practicing physicians, that's back to practitioner issue, right? Physicians are short, where nurse practitioners are short, nurses are short. It's just, this looks at the physicians. Visits per capita, there's a couple less with average visits per capita for Sweden and New Zealand. Why? Why they're lower than us? We know why ours is low, access. They're healthier. Yeah, they don't need as much care, so. Okay, so that's the list. Let me give you some of the latest stuff. The deaths, all-cause mortality for people ages 1 to 19, kids, has increased 10.7% from 1999 to 2020. And then it increased another 8.3% between 2020 and 2021. Transportation, so the 3 top in adolescents, transportation cause deaths. What else do you think? The what? Suicide, homicide, and drug overdoses. 1 to 19. How are we doing? U.S. maternal mortality has more than tripled in the last 35 years. More than tripled, with 24 deaths per 100,000 births. That's maternal death either during pregnancy or during birth or in the year following. Now, among black people, 55. More than triple the rate of white women, who are at 19 per 100,000. So, obesity, 42% in the United States. West Virginia is winning at 51. Alaska is kind of in the middle of the pack, a little more than average, 43.2% are obese. What else is there? Yeah. Oh, yeah. Suicides. Oh, drug overdoses. Drug overdoses estimated in 2021, 2022, close to 110,000 people died from a drug overdose, 2% more than in 2021. Between 2020, between 2019 and 2020, it increased by 30% from the previous year. Between 2020 and 2021, another 15%. Most of it from synthetics, fentanyl, and opioid synthetics. I know, don't mean to bring you completely down in this, but you have to see what is real and what is there. So spending, yes, you're absolutely right. So it's over $12,000 per capita in 2020, 4.3 trillion in 2021 total, which has increased quite a bit. It will go down in 2022. That data will be lower because, again, COVID expenditures here are counted, and we're spending less on that because the pandemic is behind us. So uninsured population, it's climbing up. The 18.3% of gross domestic product in 2021, again, down from 2020 because the 2021 COVID spend was less than that in 2020 when it first started. Spending growth significantly outpaces economic growth. I've heard some economists that say, if this trajectory continues, by 2080, the vast majority of what we do will be, sick care. In this, and producing very little of anything else. Not good, not good. Okay, let's talk about this quickly. Who pays for health care? Oh, yeah, I forget the questions. Oh, shoot. Anyway, maybe they're keeping up. So there was a question. Let's see if they paid attention in the cyberspace. What is the U.S. spending on healthcare per capita? We'll put that one in, and we'll put the number 3, which is the U.S. ranks the worst in which of the following measures. Click all that apply. And unless they click all of them, and I'm telling you, gotta click all of them in order to get this right. Okay, so let's talk about this. This is essentially who pays for, somebody said, you said, or somebody here, insurance, right? It's an insurance system. It is an insurance system. This is how it breaks down in the spend in 2021, which was published this year. So Medicare is approaching $1 trillion. And who does Medicare cover? 65 and plus, so older population. Who else? Right, so those who are permanently disabled, those with end-stage chronic conditions like renal failure. So yay, that's Medicare. Medicaid. Low-income populations, yes. Private insurance. Everybody who works, essentially, right? And everybody who buys it on the exchanges. So that's the largest. Now, explain to me the spend. Private insurance spends less than half per enrollee than Medicare. Why?
We have to pay for it?
The what?
We're paying out for it?
No, I mean, they're enrolled, so obviously whatever the processes and rules they go through is true, but why is it that much less on a private insurance than Medicare? And Medicare has this, it pays 80%, people still have to pay 20%, yes?
Well, then Medicare or Medicaid?
Medicare.
Oh.
Yeah. Why Medicare spends the most per a person who's enrolled in it?
Because they're older people and disabled, so they have
Well, yeah, so they have the most problems, right? They want new hips because they haven't taken of their old ones, taken care of them to begin with. Yay. So Medicare covers, imagine a car insurance, right? That would say, okay, we figured it out. We're going to enroll everybody who's for sure to get into an accident. That's the only population we're going to enroll in this insurance. How do you think that would do? Yeah, it's like in the back. It's like, nope, that doesn't work, right? There is such an idea in insurance as risk pooling, meaning in order for it to make sense, right, for the coverage, overall coverage to make sense, you enroll some people who will never, ever, ever, because, you know, they're that, and like, safe drivers, essentially, right? What's defensive driving? That's what it's called. Like, they're constantly exercising that. They're constantly alert. They're not, like, you know, putting their mascara on while in the, you know, driving to the office. I mean, obviously now you just have to drive to your mirror. To like a selfie thing that's set up stick. But still, right? So imagine, so risk pooling doesn't exist in Medicare, and Medicare covers whose money is this? Taxpayer money, correct, that only covers those with the highest risk. Everybody gets that. Do you see any issue with that? Yeah, there is an issue with it, right? Whereas private insurance enrolls able-bodied, mostly, right? People who are more well, mostly, because they're working, most of them, yeah? And so that's the, and then, you know, out of pocket is several billions there. This is the sponsorship of it. Federal government, 34%. Households outside of Texas. This is outside of Texas. 27%. Private business, 17%. So households, that means that's your premiums, copays, stuff like that, right? State and local governments, 15, other private. So you as a taxpayer, say you utilize, you pay your premiums, you go and use the doctor, you pay copays. You want to add it up for me? How much you actually pay as a taxpayer? You add 34 plus 27 plus 15. Now, it's already is here. It is happening. Yet everybody argues that, you know, somehow making sense out of this financially isn't the thing to do. We already are paying the lion's share as taxpayers, the lion's share of healthcare spend in this country. Yes?
That's why our future is so important, because our elderly are going into long-term care facilities that we are paying for.
Correct. And yet again, I hear, you know, and let me ask you this. What do you think the biggest difference is between our healthcare system and that of our comparison group, Western developed world? One major difference. The what?
How we treat the elderly and disabled?
No, well, not necessarily, but you know, they probably like to treat them good, and we like to treat them good. Yes.
Access?
Access is true, but what is different in the system itself? Why is the cost lower anywhere else, per person, per whatever? What is one major, there's only one. There's only one major difference, and you kind of like with that insurance system versus healthcare system, you kind of pointed it out. Yes?
Is it the preventative care?
Well, they are way better at preventative than we are. Yes?
Is public healthcare?
Well, it's not necessarily public in all cases. It is universal, though, in all cases. Universal healthcare, meaning everybody pays into it, and everybody accesses it. Everybody has access to it. That's what universal is done. Some of it is government-based, so completely administered by the governments, right, who own both the delivery system and the financial system of the system. But some of those countries on the comparison list, that is not true. Everybody pays universally. Everybody gets access universally, but it's administered by private sector. Meaning hospitals are private, doctors are private, all of that. Government owns none of that. Yeah. But government universally serves as a payor. Yeah. And then the argument constantly that I hear, and this is the pundit on TV and all of that. I mean, there was demonstrations when Affordable Care Act was, being debated outside with like the people with signs that said, "Government, hands off my Medicare." I'm like, well, that's nice. Medicare is government. Right? So this is the sort of misunderstanding that we all have. And again, and this clearly illustrates. It's like somehow we're all are sort of this fear-based kind of like, oh no, if the government becomes the payor, somehow it's going to cost more to all of you all. Not necessarily. Because you're already all paying for it. Right? Based on your income, you pay the proportionate share of that already, of all coverage. And yet again, the taxpayers' money directly is spent on the populations that are most vulnerable and have the highest risk. Universal systems pool their risk together, meaning young people have to pay into it. In here, we're like, oh no, I'm fine. I'm just fine because I'm in my early 20s and whatnot. I'm doing just fabulous, and just look at me. Yay, why would I pay into the system? Why would you when you don't need it? Why would you pay? What's the argument?
I feel like just because we're young doesn't mean we don't pay. I had a brain bleed at 24. So
Yeah, I mean, and again, you may need it, but on average, right, people need way less care when they're younger than when, when the hips are giving out. And that's not going to happen at 24, right? There's some accidental stuff may happen and all of that. But why should you care to pay into the system?
Is the only way that we society together?
Yeah, so societally, it works then, right? Because guess what? One of the days, young people, you will be old if you're lucky enough. And imagine the younger population saying, I do not give a hoot because I'm good. You, who cares? Just look at you, you're old. That is the attitude that we have. Is it socially well? Nope. We're taught constantly to only think about ourselves. What I do or what I think or what's happening to me, that's the only thing that matters. We've built a society that is so ego-centered. We cannot see past our noses. And we're convinced that somehow we're saving by doing that. And we're not. So that. Ooh, questions. Questions for the cyberspace. Yeah. How much do federal and state entities spend on health care? You already had the right answer. Just have to put it in. Okay. And then how much do private sources pay for healthcare? So this is the sponsorship This is where the dollars go. You know how you talked about the preventative thing? Let's find it. Yeah, it's sprinkled like a little here, a little there, a little there. What do we spend the most on? Hospital care. $1.324 trillion in 2020. Trillion. You know how much a trillion is? It never really fits in my head that many zeros. It was like a lot of zeros. You take a million, and like a million is kind of like, oh yeah, if I retire with $1 million, right? Like, I'll probably be okay. Yeah. So multiply that million by another million, and you get into the numbers that are, So 1,000 million, it's like 1 billion. Then 1,000 of those is a trillion. Then another, that's a lot of green. A lot. Why are we spending so much in acute care? What do we treat in acute care nowadays? What do we treat there? Yes. Well, we treat exacerbations of chronic conditions mostly, right? When somebody that is has a chronic condition that is poorly managed or unmanaged at all, right? No preventative stuff happens. Ends up with a bouquet of different things. And then it costs a lot to get them from there. And then what happens? Then they acquire an infection in a hospital or something else, right? And they're back, and they're back, and they're back, and they're back. And that is an expensive, expensive, expensive proposition. That care is expensive. Delivering it is expensive. And so almost 400 billion in prescriptions, all of those were needed? Probably not, right? So here's another question for the cyberspace. Oh yeah, this is just for your information. Waste estimates. Out of that, around $4 trillion, close to $1 trillion is wasted. The what? Fraud and abuse, yes. Because when the system is that fractured, it is actually easier to manipulate it and abuse it. So overtreatment, low value, that's sort of, I think, what you were referring to earlier with we do some stuff that doesn't lead. Unnecessary care is a big one, right? Unnecessary care. Why does it exist? Why do we provide unnecessary care? The what? Thank you. Some of it is that, right? The more I do as a provider, the more I get paid. Because I'm paid for doing rather than paid for doing what? No, rather than paid for producing outcomes. Right? So it's in my best interest to say, yeah, let's try it. Whether we know that whether it's going to work or not. Failure of care delivery, that's when somebody already has access and is within the care system, and we fail to deliver it to the extent that we should have. And then the kind of repercussions that come out of it and fixing of it that comes out of it costs a lot. Yes?
Mental health, drug addiction, having jaded opinions.
Yes, so mental health is a big, we'll talk about the factors, right, that affect all this in a minute. But overtreatment or low value, 101 billion, right? And why? Why else? Right? So it's chasing chasing the dollar for some providers. Why else? What contributes a lot to kind of like overtreatment? Let me ask you this. How much time does a provider have to spend with you?
Very little.
Very little. Why?
Because they're so overworked, they have so many patients.
Overwork, shortage, right? As a nurse, bedside, right? You just have no time, right? So you go and go and go, and then you throw something at the wall and hope it sticks, and then, you know, for the doctors. But what, you know, ever seen TV lately? I mean, shit whirls in the hills or whatever it is, and it's like, you know, the smiley face here, the sad face here, whatever. And it inevitably ends with, you know, no, before it ends with it, it says, and, you know, you'll take this, that all, you're gonna twirl in the hills just like she's twirling in the hills. Just take this pill. It may cause diarrhea and death. But please do ask your doctor about it. We're the only country who advertises pharmaceuticals on TV. And then what? I want to feel like she's feeling. I want to twirl in the hills. Doctor, I must have it. My mother, she gets a cold. She's in, you know, Medicare. She's at her doctor's, right? And the doctor is like, drink some fluids, rest up, whatever. It's like, no, no, no. I need an antibiotic. And finally, and she wears the doctor out. And the doctor goes like, sure, I don't have any more time. Here you go. Whatever floats it for you. The what? Well, correct, and that obviously overprescription of antibiotics leads to antibiotic resistance bacteria, which we deal with all the time, which is horrible. And when you get into practice and you get those infections in your place of work, wow. It's a lot. So we do that, right? But the system is contributing to it. It's the behavior of the consumer at this point, right? Because we consume healthcare like we consume anything else, right? Right, and we're looking for a shortcut to something, right? Oh, I'm not going to study this. I'm just going to write it on my thigh. And then, you know, because that proctor is not going to notice. I'm constantly staring at my, you know, that area. That's a shortcutting it, yes. And so it's the consumer behavior, it's the shortage of the providers, it's the system that is designed to pay for prescribing and pay for service rather than pay for outcomes, things like that. Yes?
We're also losing money with compensation lawsuits from the side.
Right, we are a litigious society, so yes, there is quite a bit in that. Administrative complexity, can somebody explain that to me? Close to $300 billion. $300 billion. Again, you know when the debates are going on in Congress and they're debating like 10 and like, no, don't, like 300. Explain that to me, administrative complexity. What does it mean? Yes?
Is that like two doctors don't know which can't decide on result?
Right, so the two doctors not communicating, that is a failure of care coordination. Right, because the system is so fractured on the provider side and on the payer side, we have very little coordination that happens between providers, right? Because guess what? If my mother didn't get her antibiotic from her primary, she'll go to her, you know, heart doctor and annoy her and be whatever, you know. But when my mother is told, you know, girl, you got to lose some weight. She gets really mad at the doctor because why? She's like, Jess, she should look at herself. And I'm like, mother, you're not her doctor. She's yours. And yes, maybe she's not leading by example. But nevertheless, what's coming out of her mouth is true. So failure of care coordination is one thing. Administrative complexity, though, that is not administrative complexity. You had something else.
Would any of that fall in like when a doctor's trying to get a script for a provider and the insurance like denies it?
Yeah, so it has to do with insurance, and it has to do with coordination between payors and providers. Now, every single payor, meaning an insurance company, and we know how many there are, right? Medicare being the largest of them, and Medicare has the most negotiating power. But every single insurance company negotiates with every single provider. And that, like doctor, imagine how much that is, and hospital, and clinic, and this, and that. And the same service costs very different, right? If you have, the bigger negotiating power an insurance company has, the cheaper the cost of delivery, right? The smaller the power they have, the higher it is. Now, and it has nothing to do with how people get paid in the system. For the most part, has nothing to do whether or not they're producing good outcomes. Yes?
I think so that the system is also a big responsibility for all these things, because if I go to the doctor is going to tell me, I just have 15 minutes to give attention to you, even that you need more time to spend with the doctor.
Right. So the shortage affects us all, right? It is not, even when somebody has access to care and somebody has the means for paying for care, right? It doesn't improve the supply of providers, right? That the shortage, and look, and the supply of providers and all, like we'll talk a little more on the nursing side in kind of the second half of this when we're talking about solutions, but it's true. And some of these, again, some of the barriers to provider development are political. Some of the barriers to provider development are economic and so on. And so we'll discuss that, and this is where you guys get involved in thinking about how to solve it. Uh-oh. I know, we're almost there. So there we go. Okay, so administrative complexity is just that. No other country in that comparison list has this problem. This is a very unique US problem in the system, and again, in the developed system world. And they don't have that problem because there's only one payor, and the payor is universal. So the payor then, it's one payor, and it's like, it doesn't need to negotiate because there's ain't nobody else there. And some will say, look, it may be not the best thing for the system, but that like, it reduces the kind of the market power, right? And the power to, and again, if we figured out a way how to pay for outcomes and not, sort of base it on random number. Look, there is, I'll give you one example. A few years ago, I hurt my shoulder shopping for, and I actually shopped for an MRI for my shoulder. And it ranged anywhere from $560 to over $5,000 for the same procedure. The rating of the providers were not like, there's no discernible difference between the, so which one do you think I picked? The $560, because when I shop on Amazon, oh yeah, if it's 2 cents cheaper over there, I'll buy it there. Totally, and we all do that, right? We just don't do it here in this system, especially when we have coverage, because who cares who what pays? I pay $15. Yay. Yeah. So administrative complexity is, it's essentially a third. And that one is not, like, notice there's not a range in that number. That is actually that year what we spend on coordinating between providers and insurers. Okay. So yeah, let's talk about, we're gonna go through this list. This is the next question for the cyberspace, what factors affect poor health outcomes. So let's talk about these, right? And actually, cyberspace, you keep answering that question where you guys just, glance at the list. And when we come back, what I will want you to do, we'll talk a little bit more about each one of those. And then you're going to tell me, as a nurse, current nurse or future nurse, how you're going to deal with this. With those systemic things. These are the things, and we've talked about some of them, and this is just poor health outcomes. High spending is on the next page. So I'll leave it up, or Brienne may fix it while we're away on a 20-minute break. Yay! So be back at exactly 20. I'm even giving you like 22. 20 before the hour, everybody. So, and if you're in Alaska, it will be 20 before 11. Yay? Everybody good? All right.
Is this an Alaska problem? For you guys?
Now I think it's 5, 4, 3. All right, and we're back. Yay, everybody. Thank you for coming back. Nobody left. That's fantastic. Okay. Hopefully you in cyberspace, you didn't leave because we're still tracking attendance, you know. Technology allows us to do that. Again, unless your name is, you know, the friendly ghost, number 35. Anyway, so we paused here. So let's dig into this a bit, and with this sort of kind of slant, I guess, of figuring out what it is that you can do, starting now and then throughout your career, in order to address things that are on that list, because those are the things that systemically would have to be addressed, right? So let's start with systemic inequities and generational poverty. What do you think? Personally, I think you already may be doing it, right? If you or your family have experienced generational poverty, I think by doing this, right? But sitting in a class isn't the same as actually, you know, getting competency, completing, doing all of that, getting into the profession, getting to better income and all of that, right? So that's individually. You can address that. But from the more, you know, if we lift it out of you and your family, what can you do? You had something?
I put down work with communities and other sectors at trying to make this better.
Yeah, I think, look, in order to address systemic inequities, right, every part of the system has to be involved in addressing solutions. So for example, I mean, I'm in Alaska this week building coalitions, right, among the state government here, like the Department of Labor and the Alaska Health and Healthcare, Hospital and Healthcare Association and Matsu Foundation and so on and so forth, and employers. So building coalitions that then can start addressing the systemic inequities that exist here in Alaska, right? And in this state, one of the bigger ones is geography, right? That is a systemic inequity that has not been truly addressed. Because this education, I mean, like, look, you probably are from around here, all of you, right? From around Anchorage. Somewhere near, but if you live in, you know, North Slope, Borough, it's tough. It's tough getting, you know, here. And so what we're trying to figure out as a coalition is how to bring nursing education to everybody, anywhere, no matter where they live in the state. And so which again then starts addressing some of that generational poverty that exists in some communities, right? Because when somebody becomes a nurse in a community, what happens? Well, it's good for them, right? Good for their family, all of that. Fantastic. What happens in the community?
You can address healthcare.
Right. So somebody starts, I mean, there's a supply of the shortage. We talked about all of that, right? There's the availability, access improves, right? Access to care in that community improves. If access is improved, you likely will see some of those things continue improving. If the hospital, right, usually it's like critical access hospital or some kind of healthcare facility that serves, and a school, right, that serve as a backbone of a community. Now, if there are providers who are available to serve that population, right, the economic activity and everything else in that population, in that community is going to be improving. Yes?
Working in the Navy hospital, they're trying to improve education to the nurses that are willing to go through these places that are very far away from
Right.
Anchorage and
Yeah.
help them. Yes.
And it is, look, nursing is one of the best socioeconomic mobility vehicles in this nation. And yet nursing is not accessible to those who, from the socioeconomic mobility standpoint, can use it the most, right? People that live in intergenerational poverty. And so these coalitions that I'm talking about building and inviting everybody into that solution solves for that, right? It solves through different mechanisms. It solves the financing of the education. I wish we could deliver it for free to everybody, right? But there's no such thing as free lunch. Somebody has to pay for it. And there's many that need to get involved in order to solve those issues, and then let people who have never had a chance to improve. So building these coalitions, I mean, from this standpoint and other things is really important. Working on stuff together, cross-organizationally, cross sectors is really, really important. And you have to lead the charge, right? It's like Mikhail alone running around across the country ain't gonna do it, right? Everybody bending together, that's what's going to start solving this. Social isolation and loneliness. While you think about how to address that, I'll give you some stats on that. Lack of social connection, again, social media is not the social connection that we're talking about here, can increase the risk of premature death to levels comparable to smoking daily. Reduces chance of survival and increases the risk of premature mortality by 29%. This is social isolation. Increases risk of heart disease by 29%. Increases risk of stroke by 32%. Smaller social network size associated with increased risk of type 2 diabetes, diabetic complications, including heart attacks and kidney disease. Chances of getting dementia for an older adult increases by 50% if they live in isolation, social isolation. Increased levels of inflammation, same as physical inactivity. Combine the two together, and wow, a bouquet you have. Has been found to significantly contribute to the development and severity of illness after exposure to viruses. What are you going to do? Yes?
A good way is to work as a CNA or a PCA. As, for example, I have a patient that's completely bedbound and lives by themselves. So the only type of socialization is when I go visit them. And a lot of times, I don't even have to clean them up or anything. I just sit there and talk to them.
Right, absolutely. So everybody can do that, right? Establishing a human connection with somebody else, and you don't necessarily have to work, right, in somewhere in order to ask the question, is anybody here needs, and it's just not just older people. Younger people experience that constantly, right? I mean, another thing that I like, let's see what else. Let's see what else you have. Again, you individually, community level, and so forth. Yes?
So something that I actually did in the past, because my in-laws lived in a senior living community.
Yep.
We actually formed a night where they would get together with others that were limited in their movement and would have card nights. In their
Organized social activities, right?
Yeah, and it's really hard.
Facilitating that.
With social media now, everybody thinks they're getting
exactly
interaction with social media, when in reality you're not getting it.
Right. So reducing the use of social media, number one. That is the number one. So you individually, again, I say, look, while you're in school, you have no time anyway, so get off that Insta. It's not going to miss you. Meta is going to make as much money as it's making, so they're not going to miss you. So reducing the use, and again, the advocacy that you have to do around this. There's all this new study that's coming out, and a whole courses. Our upcoming mental health and psych nurse practitioner program actually include a course, right, on the effects and dealing and counseling and doing all of that for the isolation and the social kind of disconnectedness and social unwellness that social media creates. And I mean, again, look, and if you want, like, it's like if you want a patient that won't look at you and go like, well, you know, she's overweight herself, so why is she telling me that? Get off the social media first, and then, or reduce your use of it, and then you can start and learn a few things on how to counsel around it, and then drive that forward. Young people, like the younger generation, the Zers and younger folks, they're completely isolated. It is just, the young gentleman back there, he's like, yep, I can vouch to that, yes. That and it's the system that we have built, right? And I mean, like, it's sparkly, it's nice, it's good, it's whatever, it recommends you a new whatever lipstick, I don't know. But influencing is, I know, it's like for some people, it's a way to, to make money. It's not a career. I mean, like, yeah, hello, hi.
So I think something else though, as like nurses, but also, if your parents, that you can do is also get together with other parents and encourage them to use like the ways to block social media for their kids or limit the time.
And send them, so limit the time for kids, send them out into the fields or whatever exists near your house. Let them go and run around and play and, and maybe like touch a real ball every once in a while rather than, whatever you do in that, virtual reality. Virtual reality is cool, but, sometimes you need other things. Okay, so there's quite a bit, and again, it's the advocacy. What the one important word to carry out, one of the important words for you all to carry out today, it's advocacy. You have to know your stuff, right? You have to know your facts. You have to know all of this. You have to know how to deal with it, and then you have to actually do it. You have to advocate. You have to engage with others. All of those things. This is not going away on its own. It is not. Nurses are instrumental, must be instrumental in solving that, right? Must be instrumental in like kind of getting the head up, looking forward. Yeah. Soon there is going to be, we'll grow a bone here from, evolution, right? So it's like to help us. Because generation after generation, we've, this is what we do. So already our postures are like, mascara. Anyway, so yeah, there's a lot there. Climate change. Is climate change a health issue? Leads to poor health outcomes.
Yeah.
But tell me how. Environment altogether, and climate change specifically.
Yes, if it's all like not nice outside and it's just stuff being all cloudy and everything, it can cause depression.
Well, right. So here in Alaska, right? I mean, like I don't know to which extent this is like not your typical June kind of thing. But yeah, you're right. So that just sheer lack of sunlight. Heard of the hurricanes that are increasing in strength? Heard of tornadoes that are popping up everywhere and destroying? Talk wellness, right? So the American Nurses Association, if you're interested in that, right now has a statement which is quite lengthy on how nurses must be involved. First, must learn how to deal with the effect of climate change, because that is not going away. And so learn how to support then people who are affected by it. And so ANA is soliciting comments right now on from different constituencies on that statement that they put together, and they're going to produce the final in the next few months. And so we all will have some guidance as to what, you know, for us as a school, we'll know what to incorporate into curriculum and across the programs. So you are learning that stuff, but that stuff is real, and it's affecting health. It's affecting mortality. It's affecting all of that, right? It's not a disconnected thing. I can tell you this, I live on the Wasatch Front in Salt Lake City. So in Utah, several days because of, and this is not a climate change issue, this is an environmental issue, for weeks at a time during our winters, we have air quality that rivals Beijing. It is that bad because of the atmospheric pressure and all of the greenhouse gases and everything that is produced is kept into the valley. It's kind of like, we're surrounded by mountains on both sides, and that is just sits in the valley. Guess, what do you think that affects? That poor air quality constantly. Yes? Exactly. How does it affect people's health? What do we have a large prevalence of? Asthma, exactly. Upper respiratory conditions. We have the highest prevalence of childhood asthma and upper respiratory conditions than anywhere else in the States. Does environment affect our wellness and health? Absolutely it does. Absolutely it does. Time to start actually talking about it, learning about it, and doing something about it. Again, you can do something individually, you can do something in your family, you can advocate in your community, you can advocate on a larger scale, but you have to. Gun violence. All the news, with all the killings and all the mass shootings and all of that, that doesn't even begin to scratch the surface of firearm deaths. The highest prevalence of firearm deaths is in what? The what?
Higher than gun?
No. In the gun, the death data caused by firearms. What is the high? It's not the homicide. It's not the mass shootings. It's suicide. And yet we never talk about that. We have the highest rates of suicide across our population as compared to the developed world. We have the outrageously high rates of teen suicide and young people suicide, and most of that occurs by firearm. Because how accessible firearms are. Does it affect health? It's the ultimate effect of health. After that, there is no preventing anymore. So, no matter what your political stance on guns is, please make no mistake in how it affects that what you signed up to protect. Health and wellness of human beings. So, should something be done about it? Should we not sell a gun to somebody who is depressed and is at the end of their ropes and can buy it today and commit suicide? Probably not. And again, this debate keeps going on and on and on of whether there should be some protections or not. They're established. Some waiting period, something. Because yes, if I make that decision, if I'm socially isolated and I'm depressed and social media is making me even more depressed and there is no access for me, there's nobody to talk to, there's not a provider that I can turn to, there's not any, like, if I decide today and I go into Walmart or wherever it is that the gun is sold, you betcha I will do it. Think about that. Population behavior and lifestyles, inadequate health promotion. What is that? Yes.
Not enough resources to be healthy?
Exactly. The system is, and it's later there, the system is reactive, right? The way we've built it is to address problems rather than, and we spend very little out of that $4.1 trillion on actually promoting health, preventing disease, preventing something from happening. It is so much cheaper to invest in that. So much cheaper, yet we don't do it. So inadequate health promotions. It doesn't exist. It should be in schools, right? Kids, primary school should be learning what wellness is, how to bring it about. Whose responsibility is it? Is it the teachers that are already like English, math, and all of that they have to do? Probably not. I mean, there's maybe some responsibility there. Is it us who know about it and understand it? The providers that are there. So let's think about how you're going to do it. Yes.
Well, as a nurse, you could go to schools and post like
Exactly. Right? And no, nobody's going to pay you for it. Newsflash. Yeah? Because you have your job, and you do that. But if you start, like, after you wash your hands and you clocked out from work, if you forget that you're a nurse and that the responsibility for this system's well-being, right, and for and health equity and everything that we're talking about is on your shoulders, oh, wow, then I've wasted my time. Do not forget, it doesn't end with your job. Yes, and some of these things, like going to your local school and saying, hey, can I do something fun with the kids? Teach them about edamame. It's not, it's very nutritious. Anybody knows what edamame is around here? Great, it's like a bean, that you go to any Japanese restaurant, they're there, like steamed edamame. And we're like, oh, disgusting. It's green. Unless something is brown, and very well crisped, it's kind of yucky. Yeah. Well, research shows if you start in primary school, not only the kids will be like willing to try it out, if you make it fun for them and all of that, and it's a very nutritious food, high in protein, high in vitamins, all of that, cheap as well, right? Then the kids take it to their families and say, hey, can I have edamame? And the parents go like, what? No, it's not a new mommy. It's edamame. So it works. But again, we have to do it, right? And this is just one of these examples of where the systemic change, we keep waiting for systemic change to happen from, like, the government will do it for us, right? The government, like, I've done my civic duty. I have gone into the ballot box, whatever. I mean, I voted, boom, I'm done. You ain't done. It hasn't worked so far. So why should we believe that works, right? Because the outcomes are obvious. They're in our face. The system that we've built, the system that we're a part of, the system that we participate in a way that we participate in it, has led us to these outcomes. If we want to change the outcomes, we have to. We must change the system. And so, no, the government is not going to do it because there's only like a handful of them, and they have very little evidence. Very little. Nobody teaches them that, right? Like, there's not a Mikhail that goes like, okay, in order to apply for this job, you have to understand A, B, C, D, E, all of that. Here's the evidence, whatever, act accordingly, all of that, right? There's not that. The change is going to come from the grassroots. Did I mention 4.5 million nurses? Imagine if 4.5 million people actually marched to the same drumbeat and actually said this, like, This is what we advocate for. This is what we believe. This is what needs to happen. No government is powerful enough to stop that. And no government is powerful enough to resolve the issues. We're so politicized, we're so polarized, we're so just like believing in different things, and most of them by opinion on both sides anyway. And it's, I believe in this. I believe in nursing. I believe that we are the backbone of healthcare, and it's ours to fix through different things. Yes?
Kind of goes off of what she was saying, like spreading the word, because like I'll find out new things that are like happening in my community that I didn't know was
Yeah.
going on from like a patient or whatever. And so then I'll have a patient that'll come in and they'll explain they have a problem in this area. I'll be like, oh, well, I just heard from somebody that this is going on over here, this like senior center that I didn't even know existed.
Yeah.
So
Sharing information, definitely. It's building the networks, right? We have to be network builders. We have to. And you are in such an amazing position of power to be listened to, right? Of course, if you know your stuff. If you wrote it on your thigh, it's not in your head. So it's like you need to know your stuff. And I know how tough this gets. Absolutely. I've been to nursing school. So, many of us have. And it is tough. And you have to dedicate your time and dedicate your attention and dedicate your energy and really, really, really dig into it, no matter how tough it gets. And sometimes you're not going to get it on the first time. And that is okay. That is okay. Allow yourself a space for failure. Allow that. Because gosh knows, the system is failing. We've allowed ourselves a lot of room for that, for the system to be failing. So it's for you to fail every once in a while, it's okay. What do you have to do with the failure, though? You learn from it, exactly. You figure out how to change the approach to it. Well, I studied. I really, really did. And I believe you. Great, but that didn't work, didn't it? What are you going to do differently next time? That is the question, right? Doing things in the same, and this is the problem with the system as well, right? Doing things in the same way and expecting a different outcome is not going to work. You have to change the approach. You have to change something in the system in order for it to produce a different outcome. Same for you and your studying and your understanding of all of these things. Poor nutrition, we talked about that, right? Yeah, ooh, see that Carl's Jr.'s commercials? Like, ooh, and they're like, there's a new one, and I don't know if it's Carl's Jr. or something else. I just saw it on TV here, or it's like some local outlet here. It's like, yeah, combine this meat with that meat and this thing and whatever, and put it on like this bun. It looks like this, and it's like, ooh, delicious, and it just flows all over you, and it's oh my, and it's cheap. Yeah, and we're like, oh yeah, it's like the twirling in the hills, when you see that sauce just like on somebody's face, and you're like, I want to have that sauce. And we go, right? Understanding very little, because education just doesn't exist, right? Consumer education, whatever. We're all, what do we believe, right? Coca-Cola tells you it's happiness. The latest is magic. They change it every once in a while. It used to be happiness for about a decade, now it's magic. Yeah, and you're like, oh yeah, of course. Ooh, how do those bubbles work? Yeah? Yeah. Is Coca-Cola happiness? Probably not. Is it magic? No, it's just chemistry. It's magic what it does to your insides. Yeah. Nobody knows. Directly connecting it to it. But the fact that we make poor choices with nutrition, where actually more nutritious options, better options that are maybe as affordable are available. It's just we don't know about it. So that, lack of exercise. Whew. Oof. How many worked out this morning? Oh, very good. Yeah, I did too. Yeah. All right, you're going to do it today, so that's good. That's good. Yeah, I got out. You kind of? Awesome. That's fantastic. Movement is essential. It's like a human need, right? We forget about it. Mascara. Yes.
So I think with lack of exercise also comes with the prevention of joint damage.
Right.
If you have that need and that want to move, but your joints, it's just painful. You can't
It is, I know, right? And yeah, the less you move, the more they hurt, right? When you start moving at mother, it's like, I can't, everything hurts. And I'm like, I love you, but you gotta get out and go like walk around rather than, she loves reading, and that's a good thing. Look, I mean, like, everybody should read every once in a while to exercise your brain a bit, right? But like, they're just walking, you know, it's like, oh no, it hurts. I'm like, after you do it for a couple of weeks, it's gonna hurt less. I promise. Yeah. You see those trainers on Apple Fitness Plus. This is I curse. It's like, no. Stop making me do it. And yet I'm yes.
Along with chronic conditions.
Absolutely.
Like I have MS and I stay pretty active to manage my MS, and we had a patient who literally is the same age with me, same type of MS, and she has less lesions than I do, yet her symptoms are worse.
Yeah.
But she doesn't have that exercise and diet component that I do.
Exactly. So a lot, right? Because remember Maslow's pyramid, it's there for a reason. You know how physiological needs are there, right? It doesn't say Coca-Cola there. It doesn't say a burger. It says nutrition, right? Food that is actually physiologically nutritious for you. Yeah. Movement, that is there. That's the wellness that we're talking about. And yes, you can manage chronic conditions really effectively, and yet we do a really poor job at it. And because why? Nurses are not engaged. Nurses don't even understand, right? Nurses are not taught necessarily. So pay attention through your studies to all of that, right? Of how, because a lot of it can be managed in a very, very cost-effective way. And yet we don't. And then we experience the outcomes that we're experiencing. Obesity, I'm back to that. 9 conditions that are associated with it, and it leads to. Care to venture? Give me a few. Yes. Diabetes. Yes. Hypertension that leads to heart disease. Yes.
Bone disease?
Right, arthritis. Absolutely. There you go. What else? I'll read it out to you. Stroke. Coronary heart disease, heart attack, diabetes, high cholesterol, kidney disease. And yet, again, right? It's like not to pick on anybody who has extra pounds or anything like that, but the messaging that continuously promoted there, which is not evidence-based. Yes, I understand that like perhaps that creates more social isolation and all of that. And it should not be a stigma. It is a medical condition that can be addressed, right? Not anybody needs to be as, like the airbrushed models on magazines. Like nobody talks about that. Not everybody needs pecs up to here, right? Like it's, please. Not that healthy either. But the fact is that we keep promoting, like it's constant messaging on social media, it's constant messaging on TV and all of that. It is okay. No, you do you. You do you, whatever you do. You can do you, and then here's what we have to pay for. Hypertension. arthritis, stroke, cardiovascular disease, coronary heart disease, heart attack, diabetes, high cholesterol and kidney disease. You tell me where nurses should stand on this. Right? And I know, look, ooh, I am stroking some nerve today. Yay! That's my job, to get you thinking about it, to provoke your thought in it. Yes, go ahead. Yeah.
I said I think I was going to say this goes back to social media, because there's that body positive, so it doesn't matter if you have to be positive about somebody.
Yeah.
If you mention poor outcome, they will destroy you.
I totally, yeah. I'm sure I'm gonna, like, good thing I'm not on social media, right? Because I'd be getting some, like.
That's hesitancy from helpful
So,
prevention.
it is because that is, again, but because something is baked into the system doesn't mean it's right? Or doesn't mean, and again, I'm not promoting shame. Shame is horrible. Fear is horrible. All of that, anything that is based on things that are, based in shame or fear are horrible. It's not about shame. Be positive about it. That is fine, right? But it doesn't excuse not doing something about it, right? You can feel proud and you can still do things about it. You can do all sorts of stuff, right? One is not exclusive of the other. It's just, but what we do as nurses, right? And it takes courage to step into that arena with a patient, like like a doctor with my mother, and she, like, literally, I'm telling you, and then she complains to me. How dare she? How dare she? I'm beautiful. Yes, you are, Mom. Yes. And yet everything hurts. So let's talk about that. And your heart is not in the best shape. And this and that and everything else, right? And hypertension and all of that. And how many pills are you taking? You had something.
Yeah, I think the same goes for like our drug epidemic. Like,
yes.
Instead of, well, I gave them Narcan and sent them home on their way, but did you give them recovery options? Did you, ask the social worker to come in and see them about, well, let's talk about rehab. Let's talk about how to get you away from this. No, here's some Narcan for the next time you overdose.
Exactly. It's exactly it, right? So we do not manage that. That's the, right? Drug addiction is a condition. It's a medical condition. It's a psychological condition as well, right? You cannot blame the patient for having the condition. And yet that's our answer to everyone. Well, it's like, go change, rather than actually guiding somebody in managing that chronic condition, because that chronic condition is never going away after somebody is in it. It never is going away. Alcohol abuse is a chronic condition that never goes away. People go into remission forever sometimes because they are giving the resources to manage it effectively. Same with substance abuse. It is a chronic condition that after you get it, it is not going away. But systems must be set up and guidance must be provided and facilitated in order to do that. Yes?
It is so important as healthcare providers to look at drug addiction addicts as people. Because one of the main reasons I want to be a nurse is because this treatment from health providers on drug addicted people, continuing our...
Correct. The stigma, it's the same stigma that shouldn't exist, right? We're so embraced body positivity. Yeah, that's fantastic. But again, it's not healthy. But look, we've embraced it, right? Same thing. We have to embrace the human being and then help the human being get to a better state of wellness, get to a better state of health. So the healthcare system, it says it all there. We've built it after the World War II, and so it's really, really good in trying to address the reactively things. And we talk a lot about today that advocacy or proactive prevention or effective management of chronic conditions and whatever doesn't exist. And yet I can bet most of you sit here and like, oh, I'll work in NICU. Yeah, ICU is my place because that's so sexy. You know, drip, 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 drip. Where you actually need it is chronic diseases management, population health management. This is where we can make the most difference as nurses. Not keeping somebody alive for additional 5 days when they're terminally ill. That costs through the roof. The last 2 weeks, and the research shows for Medicare, the last 2 weeks of life cost a lot. Because you're like trying to prevent it without really thinking about any of these interventions that are happening that are so expensive will prolong life by days. And yet it's a taboo. Oh, what do you mean? Well, and then young people are like, nah, I don't want to pay for that. Into the system. Yeah, and we should be kind of reimagining how it is. Poor access and quality, disengaged financial sponsors. Employers mostly do absolutely nothing, right? They pay and they pay and they pay and they pay. Here at Nightingale, we pay and we're like, hey, here's a wellness program. And if you do certain things, right? You move, you eat well, you drink your water, all of that good stuff. Guess what? We pay you for it. Yay. And then give you premium breaks on your insurance. And guess what? The population, the collaborator population of Nightingale becoming healthier and healthier and healthier and healthier. Yay for Nightingale. Does your employer do that? Those of you who work? Yeah, and some of you, yes, and most of you, no. Whose job it is it to convey to your employer that this is a good thing for them in the long term financially, to invest into your wellness proactively, rather than constantly pay for the stuff on the back end, which is very, very expensive? Right, so that inability we've talked about quite a bit, provider clinician shortages, cost. Finally, this list. We talked about the first one, right? The system is set up to pay per service, not for performance. Should we demand that the system change and hold ourselves accountable to the outcomes of the care that we provide? Those organizations that we work for that provide care? Yeah. And yet again, the financial system isn't set up. So imagine 4.5 million people saying, hey, it's not just for Medicare, because Medicare, that's who does it through the Affordable Care Act, as a matter of fact. Medicare mandates performance to providers and says, otherwise, I'm not paying to you at all. And when federal money goes away from the provider, guess what happens? Bye. The provider cannot exist because nobody else is going to pay him because the outcomes are poor. That's, so that's overprescribing, twirling the hills. I talked about that, right? Education, education, education. Mom, you don't really need that. Walk. Unnecessary diagnostics, right? This is lack of care coordination. We'll go from one to the next, and everybody's like prescribing, oh, go do this test, go do that test, whatever. It's like, and ineffective. Coordination, we talked about that. Litigious society, somebody said that. We described billing and coordination of administrative costs. We've described the lack of focus on health promotion, shortages, and then consumers. That second one under consumers. Oh yeah, that's not gonna happen to me. The picture is right there. It's going to happen to you. eventually, somewhere. If not that, something related to that. And yet, right? And now with the vaping and all of that, it's so cool. It's like, who needs Game of Thrones? Of dragons everywhere.
So, I have stated to people just chatting, imaging yearly to catch cancer before it gets so bad that we have to spend all of this money for chemo. Would you say that's unnecessary, diagnostics and testing, or would that be preventative that you would think would be?
It depends, right? So the question is around imaging, around and kind of doing sort of preventative screenings and paying for that, right, rather than catching something too late. It depends on that individual, right? Because again, when we're talking about equity, right, it is what that person needs, and based on not my desire, not my wish as an individual, but actual evidence that exists. If somebody has, genetic predisposition to something, we should be screening, right? If I keep telling my brother, who's 40, I'm like, go and have, like for 5 years now, have a colonoscopy, because the entire family line, and I started when I was in my early 30s, removing polyps. If I haven't, but I knew family history, right? And I am educated enough, right? And so, if I haven't done that, guess what? At 50, I would have colon cancer. Colon cancer, absolutely preventable, right? So it does depend on risk factors. It does depend on family history. It does depend on all of the evidence, everything that we know. And if the evidence points to the fact that we should be doing something preventative or screening preventatively, guess what? We should be doing it. If the evidence doesn't point in that direction, then it probably would be unnecessary. So the big question is depends, and you got to learn your stuff to know when it's appropriate and when it's not appropriate, and when to guide and advocate for your client, for your patient, for the population accordingly. You had something, yes?
Something that goes along with that is also the administrative costs.
Correct.
Because then, if you have somebody who has, say, breast cancer or lung cancer in their family history, you're going to be fighting those insurance companies to have them start imaging early to do the early detection. So it's like,
it is an uphill battle with all of it, right? But let me again convey this. Yeah, I'll take a couple more comments and then.
I think that it goes both ways too. Like when I was trying to get my diagnosis with MS, I had all of the indications but no cognitive deficits.
Right.
So this
Right.
old crusty doctor who studied MS for so many decades, he knew better, but they were changing the criteria.
Correct.
Had I been diagnosed at that time when I first saw him, I only had 8 lesions then. By the time 4 years passed by and I saw a new doctor, I had 22.
Yeah, it's unfortunate, right? And the rules, the system rules as well. There is technology that's available now, right? The AI assistance that's available, all of that is available. But if the policies are not structured like provider policies, right? If they're not structured to use all of that information together, and sometimes it's nurse's gut, right? Like after you have been in doing this for a while, and you walk in and your gut tells you something, after you've been doing this for quite a while, trust the gut, and then if something else says differently, you have to continue. This is where advocacy comes in, right? You have to continue advocating for your patient, your client, and all of that, and like considering all of this evidence that comes at you. Yes?
I'm an MRI tech.
Yeah.
And one of the things that's like for breasts and breast milk and all that, and they push the MAMs, and then you can go to higher MRIs and you have them. I do know that insurance is getting better at allowing people, not only personal but government insurance, on preventative care as far as your screenings go.
Right. Yeah. So insurance is getting better. I'm gonna stop here because we gotta wrap up. But you know, the one thing, not the one thing, but one of the many things that I hope you carry out of this is that again, 4.5 million people. If 4.5 million people had the skills and started advocating and doing all of that, and actually ran insurance companies in the absence of universal coverage, right? And were in the government and making decisions. We're in the Department of Health and making decisions. We're at the CMS and making decisions, right? We're in Congress. Nurses are 4.5 million of us. We're nowhere to be found on governing boards of hospitals. And again, it is not the lack of maybe it is the lack of education and like really understanding our role in it. But that is my hope, right? Because again, like why do you think Nightingale is doing what it is doing and how it's doing it? And what you're learning and what we're exposing you to and how we go into the communities and try banding the communities together. Because this one is a nurse, first and foremost, right? That is my answer, but like I'm one person out of 4.5 million. And obviously we have 600 collaborators, though, many of whom are nurses, who are contributing to this. But it's everybody, that's not enough. Everybody needs to get involved in order to change the system, to change the unsustainable path of spending, unsustainable path of the healthcare outcomes that are just not. We as a nation deserve better. And nurses have to be the number one answer, not anything else. You are the answer. If you start thinking about it, if you start sort of processing it and putting your nursing hat on every single time, no matter what's on TV, no matter who says what, put the evidence on, put that thinking on, and then ask yourself, what can I do? What should I be doing? And nothing is not the answer. And right now, what you should be doing? Learning and learning and learning and learning so you can show up in Congress later on and be like, hey, colleagues, let me tell you. So that's look, I have so much hope for the future. All of you, that's the future of this. So drive it forward, do it. Just do it. It's like Nike, It's a check mark. Do it. Swoosh. They call it a swoosh. Be a swoosh. Make the change. So on that, I am going to say thank you for showing up. Thank you for participating. Thank you for listening. You can email me. I will never change your grade, so don't even try. I have no such power as the CEO. But if you want to talk about any of this, right? Connect on LinkedIn. You can find me on LinkedIn. If you need any word of guidance or advice or anything like that, all of you here, all of you out there, I'm available to be, to provide some coaching and mentoring and whatever else and whatever it is that you're trying to do to change this what we have. With us today. And again, if we band together and do it, the change is going to come. It is absolutely will come. And I'm hopeful about it. I'm hopeful about the future. And thank you. And flame forward, everybody. Say it. Say it back. Flame forward. Flame forward. There you go. All right. Thank you. All right. Don't worry.